Okay, students, we're going to start our recording for this week. Okay, so chapter 4. Hold on, let me make sure I am where I want to be. Hope we don't have any interruptions. It's always a crapshoot here at my house. Okay, so let's see. Here are your learning outcomes for the chapter. Talking about disorders, common disorders of common gynecological disorders. So a couple of these slides I'm just going to run through because these are basically definition slides, and they were on your study guides. So amenorrhea, dysmenorrhea, amenorrhea meaning no menses, and there is a primary and a secondary. We'll kind of go over that real quick. So the treatment depends on the cause, of course. Dysmenorrhea is painful menses. So that's either primary or secondary. Primary related to the actual menstrual period, and secondary related to other factors. Now, and of course, treatment is generally the same with dysmenorrhea, but you do want to find the source, the reason, and treat that. But when we treat pain, of course, one of the big things that we want to recommend as far as pain medication is our NSAIDs, because they interfere with prostaglandin. Prostaglandin is what causes the painful, or what causes the uterus to contract, which leads to pain. That is something very important for you guys to remember. I know I've said this before in previous lectures, but that is something that is really important for you to remember. So primary amenorrhea is when the menstrual cycle never occurs in the adolescent person. Okay, so if it's well, yeah. So it's just basically it never occurs. Now, I wanted to point out the cause of it being pregnancy, or a missed abortion, or lactation, of course. If she doesn't have, if she never has a menses, then how can she become pregnant or have a missed abortion? Well, that's because, remember that menstruation, the menstrual cycle itself. Hey, the menstrual cycle itself is very irregular in puberty until the young child or the girl, until her hormones are functioning at a normal level. So that may take, a couple of cycles, that may take a couple of years, who knows. But she may ovulate and not have a menstruation and end up becoming pregnant. So that's how that can be one of the causes. Secondary amenorrhea is when she doesn't have any menses for 3 months, and she previously had menses, or if she previously had regular menses, or 6 to 12 months if she had irregular menses. And then you can see all the possible, some of the possible causes for secondary amenorrhea. So we want to find out why she's having the amenorrhea, and if it is related to one of these things that we can possibly treat, then of course we're going to do that and hope that things start working appropriately. Okay, so dysmenorrhea, we said, is painful menses, and so they can be also associated with nausea, vomiting, diarrhea, and headaches, lightheadedness, a response to the pain, and also a hypersensitivity to the prostaglandins can also cause this. Okay. All right. So, of course, we're going to recommend pain medication, and highly recommend an NSAID because of its inhibitory effects of prostaglandin. But then if there is some other thing that's causing the pain, then of course we want to treat that some other thing, and then hopefully fix this problem. Okay, so we said primary is, mostly related to the effects of the hormones. For menses, okay, and then secondary is there is some other physical cause for the dysmenorrhea, and we need to find those. You can see some of those common causes. We need to find out what those are and see if we can treat those, okay? Other comfort measures, of course, are relaxation and breathing techniques. So this would, this person would have to do this all the time, relaxation and breathing. Massage and meditation. Application of heat. So when she is having those intense cramps, she can take her NSAID, put a little heating pad or some sort of heat on her belly, and usually that helps alleviate those pains. Exercise and rest, we already said, NSAIDs. And if this is something that happens every cycle and it's just debilitating, and the person is not wishing to have a pregnancy, we can put her on contraceptives, or and that will decrease those symptoms. Okay, abnormal genital bleeding. I hate this slide, and I meant to take this slide out and just give you the definitions I wanted you to know, because this is very confusing. I mean, I'm even looking at this and I'm like, what the heck? Okay, so abnormal bleeding, this is abnormal. This is more than what we expect with normal menses, okay? So one term that you can count on knowing is menorrhagia. So that's excessive bleeding, either in quantity or time. So she's bleeding a large amount, and or she's bleeding a lot longer than the normal 6 to 7 days, okay? Now where we get into confusion is the next 1, 2, 3, 4, 5. Like, this is crazy. So menorrhagia, menomenorrhagia, polymenorrhea, and intermenstrual bleeding. So I just want to, besides the menomenorrhagia, so that is too much bleeding in amount and in days, along with abnormal bleeding during the menstrual cycle. So these other ones are abnormal bleeding, the menorrhagia, the polymenorrhea, the intermenstrual bleeding. These are all related to abnormal bleeding within the menstrual cycle, or at abnormal times. So she's bleeding more frequently than every 28 days, or she's bleeding irregularly throughout the menstrual cycle in addition to her regular menses. So I just kind of want you to clump those terms together. When you see menorrhagia, polymenorrhea, or intermenstrual bleeding, you're going to think that this person is bleeding abnormally throughout the menstrual cycle, throughout that 28 days. So she's bleeding more often than every 28 days. She's bleeding irregularly in irregular amounts, like 2 days she'll be bleeding, or she'll have a menstrual period every 21 days around the consistently. So this is just during bleeding outside of the normal menstrual cycle, okay? So just clump all those terms together and don't worry about it. But menomenorrhagia is, just know that she's bleeding heavily during these abnormal times, or bleeding too long during these times. Oligomenorrhea is she's bleeding less frequently then, I mean, she's bleeding more than 28 days, but somewhere around 35 days and maybe even smaller amounts. Okay. And then post-coital bleeding is bleeding after sex. So we shouldn't be bleeding after sex. So that is an abnormal bleeding pattern. So when we have abnormal bleeding, of course, oops, too far. No, I guess not. We need to find the source or the reason why. Is she bleeding from her uterus, or is it from her cervix, or is it from her vagina, or is it from her urinary tract? Where is it from? And once we find out where it's from, then we can focus on what is causing it, okay? Once we know where it's from and what's causing it, then we can kind of diagnose and decide how to treat her. Okay. So here is just, in the different life stages, what could some other problems be outside of the menstrual period. So abnormal genital bleeding. So in the adolescent period, she could be anovulatory. She could be on contraceptives. She could be pregnant. She could have polycystic ovarian syndrome. That's what POS is. It should be PCOS. She could have a clotting problem. Okay. Midlife, of course, we usually see things like pregnancy, some structural lesions. So she has some genital urinary lesions. She can be anovulatory. She can have PCOS. So you can look and see there's all these reasons why in these different life stages. These are the most common reasons why we would see abnormal genital bleeding. And then once we know what's causing it, we will know how to treat it. All right. Moving on to vaginal infections. So normally, the vagina does have a lot of normal flora, bacteria, and yeast that maintains the health of our vagina. Okay. And our pH, the vaginal pH is usually very acidic, less than 4.5. So if that environment is messed up in some way, shape, or form, like for some reason we do not have our normal flora, then that could set us up for abnormal growth of bacteria that's not part of our normal flora, or just because we have too much of the good bacteria or too little of the good bacteria. So those are all reasons why we could possibly get an infection. And our pH could be off as well. So that could also lead us to developing an infection. So we do want to teach our patients about normal vaginal health, because this vaginal discharge, normal leukorrhea, can be bothersome to some people, and they might want to, or they might think that there's a problem, and then they might do something like douching, or we want to teach them about the normal vaginal discharge. And if they're not having this normal vaginal discharge, that is also a key indication that there might be a problem. So early and late. So early means in the first half of the menstrual cycle. Okay, the vaginal discharge should be clear, thin, and stretchy, because of the effects of estrogen. In the late part of the cycle, or the last half of the cycle, then it should be thick and tacky, from the effects of progesterone. Now, if the discharge is different than those expectations, then we want to tell our patient that she needs to come and get checked. Now, the other thing is we want to discourage douching, and a lot of women do it, and all the ads on TV make it sound like that's something that we need to do, and it's not. Of course, that's my personal opinion, but it's also backed by medical science that douching does wash out all the normal flora of the vagina. If it washes out the normal flora of the vagina, and if it changes the vaginal pH, then we're at risk for infection. So that's not something that gals should be doing. So we want to be discouraging that. Other things related to vaginal health, of course, is cleanliness, perineal care, wiping front to back, not using a lot of lotions and smelly things on our vagina or in our vagina, but even on our vulva, not wearing really tight fitting clothing, trying to make sure our underwear are cotton lined. What else? There was something else in my brain. Of course, not wearing things or keeping things on us that are wet. Well, and so you think about like incontinence or something like that, like making sure that we change our garments or our pads or something like that to make sure that we maintain as much dryness as possible. And then when we're when we're done swimming, and being careful about where we're swimming. I mean, this is a crapshoot because I took care of a young gal, very young, and she was swimming in a reservoir, a local reservoir, and she got some sort of vaginitis, some sort of infection because of the gunk that was growing in that reservoir. So we want to be careful about where we're swimming. We want to be careful that we clean after we swim, things like that. But we do not want to be douching. All right. Vaginal bacteria vaginosis. So it's kind of it is associated with sexually transmitted infection, but is not a specific STI. Okay. Anyways, that being said, it's the most. I don't know why they say it's the most common vaginal infection. I think yeast infections are the most common, but who am I? I don't know. But it's the most common vaginal infection. It's related to the overgrowth of lactobacilli, which is one of our normal floras. Okay. There are other organisms that can cause this, but the hallmark signs and symptoms of BV is thin, white, grayish, stinky, fishy, yucky odor, discharge. Other than that discharge, usually the women are asymptomatic, and a lot of times end up coming for their normal yearly women exams and are diagnosed with BV. But anyways, diagnosis is done with a positive whiff test. That sounds horrific, but you put it in this KOH solution, potassium hydroxide, and then you smell the terrible odor. But a lot of times women with BV, you don't even need to put it in this solution. But anyways, the other way is that we will do a microscopic slide wet mount, where we will put a sample of the vaginal discharge on a slide, and look for the typical clue cells that are also diagnostic for BV. And then if we were to do a pH on the vaginal discharge, it would be greater than 4.5. Okay. And then if you have someone with BV, you probably should suggest screening for other sexually transmitted diseases, because it's just kind of part of that whole cluster of things. Now, if we do have a gal with BV, we treat her with Flagyl, and she can have an oral dose twice a day for 7 days. The one thing we want to instruct people who take Flagyl is not to drink before, during, or after treatment for 24 hours at least, before or during treatment. because it just causes really intense side effects: abdominal discomfort, nausea, vomiting, headache. Take the medication with food. We don't treat women that are pregnant or breastfeeding. Well, at least in the first trimester of pregnancy. If for some reason we can't give her Flagyl, we can give clindamycin and or tinidazole. But usually the hallmark treatment is Flagyl. Okay, yeast infections, candidiasis. Okay, symptoms are extreme, intense vaginal and vulva itching, local irritation, red, and you can just tell someone has been scratching the skin off of their vulva. It's really bad. They can have a thick, white, cottage cheesy-like discharge. Okay, we can diagnose this. A lot of times we just diagnose this based on signs and symptoms, or seeing the vaginal discharge, or seeing, you know, the appearance of her vulva. It's all red and edematous. It looks like someone's been scratching it to death. We can do the KOH smear and see yeast cells, and then we can treat her. But the treatment is over the counter. Well, unless it's really severe or it's recurrent, we might need to do a prescription for her. But it's over the counter with Monistat, and Lotrimin. Okay. And of course, you know, you can rule out STDs if you need to, if you feel she's high risk. But just because a gal goat comes in for a yeast infection, we're not always doing STDs on them. So she may not be an at-risk person. She may not be concerned, but if you feel like she's at risk, you may suggest it. But yeast infections are not typically related to sexually transmitted diseases, is what I'm trying to say. They're very common, and I think, oh no, I sure didn't. So they're very common. And so one of the things we might be telling our patient who gets yeast infection, I mean, if she gets one and never has another one again, then that's great and fine. But we might, if we have someone who gets recurrent yeast infections, we might want to be talking to them about ways to prevent it. And some of the ways to prevent it are, of course, not douching, to wear cotton-lined underwear, to drink or to ingest dairy products. Like we usually tell them to eat yogurt, so that lactobacillus in the yogurt, those good probiotics, those good bacterias in yogurts are helpful. Not wearing tight-fitting clothing, avoid douching, avoid perfumes or deodorants or things. Maybe even avoid bubble baths and things like that. Making sure that they void before and after sex, and even make sure that they don't have sex during their menses. That can also be set women up for yeast infection. Okay, all right. Vaginal carcinoma, or cancer of the vagina. It's pretty rare, but we have seen a lot of it with DES exposure. We usually see it in women over 50. They could have symptoms, or they could not have symptoms. But if they did have symptoms, we could see vaginal bleeding, foul-smelling vaginal discharge, dysuria, dyspareunia. Do you remember what those are? Dysuria, painful urination; dyspareunia, painful intercourse, or pelvic pain. And so you have a patient that comes in, like, these are very common symptoms to everything, okay, related to the genital urinary system. So we'll have to do some diagnostic testing to make sure this is cancer. So the most common types of vaginal cancer are the squamous cell and adenocarcinoma. So we'll get biopsies and check and see which kind she has. Treatment for it is either surgery, with radiation, with or without radiation, with or without chemotherapy. Chemotherapy probably for the adenocarcinoma, but not so much for the squamous cell. I'm sorry, my birds are being really loud, but I can't go in the other room because my other birds are in there. All right, toxic shock syndrome, primarily caused by Staph aureus. It is most often associated with tampon use. Now, this is not something that we see so often today, because with tampon use, they had some products on the market back in the 70s and 80s when this was really prevalent, that were super absorbent and had materials in them that we have now associated with the risk of developing toxic shock syndrome. So those are actually not on the market anymore. There are still tampons out there that are considered super absorbency, but we just really need to instruct our patients about the use of super absorbency tampons. They are not so that you can use them and never change them for 24 hours, or it's not something that like you want to put in there and use for your one for your whole entire period, or for even days of your period. So super absorbency tampons are for that day or those days where your flow is very heavy. Okay, but even then, you're still changing those tampons at least every 6 hours. Okay, so anyways, we need to instruct appropriate use of tampons. Vaginal barrier contraceptives are another risk for developing toxic shock. So we need to make sure that we're instructing on appropriate use of those contraceptive devices. This is rare, but this can be fatal. Okay, so this is big. This is a big deal, toxic shock. Symptoms are fever, rash, vomiting, diarrhea, hypertension, very nonspecific. We diagnose that by clinical findings. So her signs and symptoms, we'll do our history and find out she's using super absorbent tampons or whatever, or she's left her vaginal ring in for 6 days or something like that. I don't know. But anyways, we'll do a CBC. We'll see she has an infection. And then they do need hospitalized. They need on IV antibiotic therapy, aggressive fluid replacement therapy. So this is really bad stuff, but thankfully we don't see it much anymore. Okay, urinary tract infections, which we see all the time. Remember, we can have symptomatic and asymptomatic tract infections, often caused by E. coli. Anyways, we have our upper and lower UTIs, so cystitis or bladder infections. So that's the lower genital tract. Signs and symptoms, if she's having them, are dysuria, urinary frequency, urgency. Her urine can be cloudy or foul smelling. She can have dysuria is already there. Suprapubic tenderness. Or pyelonephritis, which is an upper GU tract infection. So her ureters or kidneys, it will be like kind of more severe. They usually are symptomatic with this, so they have fever, chills, flank pain, CVA tenderness, nausea and vomiting. Those people, so a cystitis is probably just oral antibiotics. But a pyelonephritis is probably going to be IV antibiotics. Risk factors, anything. That's what I say. Age extremes, so the very young, the very old. If they have tract obstructions, of course, urinary tract obstructions, of course, they're at risk. If they have retention, they're at risk. People who have diabetes are at risk. People who are sexually active are at risk, so we want to make sure that we're instructing patients to make sure they have, the common practice is to void after intercourse, and to not have intercourse during your menses. People who use diaphragms or devices, people who use spermicide are at increased risk. People with altered immunity are at increased risk, of course. And then the pregnancy, women who are pregnant are very at risk. And typically those are the people that you see who are asymptomatic. Anyways, we can just diagnose on signs and symptoms if you feel your patient, if you trust your patient and their explanations. But usually, typically we do a clean catch urine sample, we send it off, we see white cells, we see bacteria, and then usually treatment is antibiotic therapy, Bactrim, Spectrum, Macrodantin, or Augmentin. If they have recurrent tract infections and we've treated them with this and they've come back, then we'll probably do a CNS to see specifically what they're growing in there. Maybe it's something different than the common, and we may need another antibiotic therapy. Pyridium is a medication that we give that that helps the bladder pain, the dysuria, and the suprapubic pain. And if we do give pyridium, we need to educate our patients about the color of their urine. So it will be a flaming orange color. So anyways, and then I think we've already talked about strategies to promote bladder health. Oh, maybe we haven't. So those would be, if we could suggest the person would void more often, not hold their urine like a nurse does for 12 to 14 hours. If they would void more often, making sure that they empty their bladder after intercourse for sure, being hydrated, drinking adequate amounts of water, or drinking cranberry juice, wiping from front to back, avoid douching, avoid using harsh detergents or soaps or something, avoid using powders and sprays on their vulva, and wearing cotton underwear, avoid tight-fitting underwear and pants. Anyways, okay. Oh, wait. Make sure. Wait, where'd I go? Oh my goodness. Okay. Yes, that's it. Okay, endometritis, or ptosis. Endometriosis. So that is the abnormal growth of uterine tissue outside of the uterus. So it could be on the fallopian tubes, it could be on the ovaries, it could be outside of the uterine pelvic cavity, it could be on the bladder, it could be on the bowel. They can migrate to the brain, to the nostrils, to the lungs. It could go anywhere in the body. Now, the problem is with these abnormal cells, what happens is these uterine cells that are outside of the uterus, they still react to the normal hormonal stimulation of the menstrual cycle. Okay, so they will do what they do in the uterus. They can proliferate and grow. Okay, just like in the uterus, which can cause problems in itself. And then they become ischemic, and they can even bleed. So wherever they are, they could be bleeding into the tissues, and they can become trapped. They can cause blood-filled cysts that can cause inflammation, pain. It could cause dysfunction of that organ or wherever it's on. It can cause scarring and adhesions and pain and all kinds of problems. So risk factors, we're shooting in the dark here. So early age of menarche, short menstrual cycles, low birth weight, no pregnancies ever, heavy prolonged menstruations. There can be a familial component. high parity, so either nulliparity or high parity, so lots of pregnancies, no pregnancies, whatever, it's probably a risk factor. We've already talked about some of the symptoms, of course, pelvic pain, and then pain and problems with organ function wherever those uterine cells are, can cause problems with that system. Okay. So we diagnose and we stage it in severity. Diagnosed it by laparoscopy to visualize these lesions outside of the uterine cavity. If we, for the treatment of them, the treatment is based on the desire for pregnancy. So if someone wants to be pregnant, of course, we cannot use any type of medications that are going to inhibit ovulation, that are going to inhibit gonadotropin releasing hormones, that are going to inhibit and ovulation, all those kind of things. But that is one of the treatments. So if they're not desiring to be pregnant, then we can use those treatments. If they are desiring to be pregnant, then we don't really treat. We just have them try to get pregnant if that is, if it is the time. So if it's not time for them to have a baby, they don't want to have a baby, put them on these medications, and then when they're ready to have a baby, stop these medications and then hope for pregnancy. But otherwise, we could also do surgical removal of these lesions, possibly depending on where they are in the body. We can surgically remove the adhesions or release the adhesions. If there are blood-filled cysts, we could remove those cysts, drain those cysts. And then we could just do a hysterectomy to prevent further migration of those uterine cells. So, whatever treatment that we're going with, there's going to need to be a lot of patient support and counseling, education on other therapies, CAM therapies, but patient support and counseling. Because this, I mean, the way I described it, I don't know if it sounds really bad, but I've met some people with endometriosis that were ready to commit suicide. It's that debilitating. It really affects their life. So we need to get them maybe into some supportive therapy, some supportive counseling. Maybe even refer refer to different resources online and things like that, where they can get support and learn about new treatments and learn about new CAM therapies that help with this. Okay, and then especially if you've got a young woman who has endometriosis and maybe she does want to have babies, or maybe she does have babies and she feels like she's done having babies, but to end up with a hysterectomy, maybe, then she has to accept the fact that she can never change her mind, is what I'm saying. Okay. So it's a big deal. Okay. Leiomyomas, or uterine fibroids, or fibroid tumors. Most of these are benign, but they do cause some problems. So, and why some women have it and some don't, it's still indeterminate, and it may be fluctuations or estrogen dependent. We see it a lot with increasing age. We see it a lot with no one's ever been pregnant before. Of course, smoking is a risk factor. People with prolonged menstrual cycles. Okay, if she has fibroids and they're not causing her a problem in life, then there's nothing really we need to do about them. And then usually after menopause, when we're not having those high levels of estrogen or hormones, they typically regress. Okay, but but a lot of times we end up getting hysterectomies because of them. They can cause pain and discomfort. They can cause problems with pregnancy or implantation, and it is the leading reasons why people get hysterectomies, is because of these fibroid tumors, especially if they're causing them pain and discomfort, especially if they're causing them dysfunctional uterine bleeding. So anyways, symptoms are they can have abnormal uterine bleeding, they can have pelvic pressure, painful intercourse, dyspareunia. They can have problems with urination and defecation depending on how big those fibroids get. Or she can completely be asymptomatic. It's just very dependent on the person, how many she has, how large they get, and things like that. We can diagnose these because the uterus can become larger because of these growing fibroids. The uterus definitely can be misshapen or an irregular shape because of these fibroids. We can see these on ultrasound. We can see these on hysteroscope or laparoscope. But definitely if we're going to be doing treatment for these, especially if it's a surgical treatment, we need to make sure it's not a pregnancy that we're feeling. Okay. So treatment is we can give contraceptive steroids we can give intrauterine, we can place intrauterine devices. We can use gonadotropin releasing hormones, anti-progesterone agents, things like that. That's the drug therapy. I will, well, I didn't have this type of intrauterine thing here, but a little TMI, so just a little experience on a person I knew. She had fibroids, and she was trying to get pregnant and couldn't get pregnant, and then ended up, she had tried so long getting pregnant that she became advanced maternal age and decided, well, I don't want to risk getting pregnant at this age, so she tried a long-term contraceptive therapy, and it was an intrauterine, it was an IUD, and she had so many fibroids that were so large and all over her uterus that the IUD was extremely painful. So she had to have that removed, and then her pain never stopped after the removal of the IUD. She could not even bend over and tie her shoe without having pain. So she ended up getting a hysterectomy. And when she got her hysterectomy, I had the privilege of seeing what her uterus looked like. And I don't know if you guys remember these toys for kids. They were round plastic balls. They were bigger than a softball, or about the size of a softball, hard plastic. But all over this ball were these knobs. And then you would turn on the on button on this ball, and it just vibrated and bounced around, and it was very fun to play with. Well, that's what my uterus or this patient's uterus looked like, is that thing. Anyways, so that was the reason why she was never able to get pregnant, is because of all these fibroids. But anyways, surgical procedures, we could do a uterine artery embolization, and you need that special radiology guy. You need an interventional radiologist to do this, and there's not a lot of those around. As a matter of fact, I don't even know if we have them in Missoula. But anyways, basically it is putting it's putting some sort of blocking agents in the arteries that feed the fibroid, and so cutting off blood supply to the fibroid, and then they disintegrate and go away. Myomectomy is just surgically removing the fibroids. Hysterectomy is just removing the uterus. They can do laser surgery, electrocauterization, to remove those. The ultrasound surgery, where they hit these fibroids with ultrasonic pulses, I think, and then that destroys them, and then all is well. But that doesn't mean that these fibroids won't come back. They could come back, they may not come back, but those are definitely different options. Now, if this person still wants to become pregnant, these other procedures besides the hysterectomy, these other procedures, she could possibly become pregnant, but depending on the scarring that is left after the removal of these fibroids, places that scar in the uterus are not places that a placenta can implant to. So it may be a problem. Oh, well, here's my explanation on those different procedures, okay? So you can look over those. All right. Back to abnormal uterine bleeding. So there's this mnemonic, Palm Cohen, that they use to rule out or to direct us in trying to determine why this uterine bleeding is occurring. So the palm part of the mnemonic, those are structural problems within the genital urinary tract. The Cohen problems are more of a pathological dysfunction, a non-structural reason. So she has a clotting problem, she has an ovulatory problem, so there, and then she could have some other problems. So for abnormal uterine bleeding, we will use oral contraceptives. Those will, any type of contraceptive actually can control abnormal uterine bleeding to the point of where, depending on the contraceptive she chooses, she may not have any bleeding at all during her menses. Tranexamic acid, that's a thrombolytic, and we actually use that in labor and delivery when we're having a patient who's having postpartum hemorrhage. It's a new therapy that we're doing. So she can have a D&C, that's a dilation and curettage, where they go in and dilate the cervix. They go in with instruments and they scrape the uterus. They scrape the linings of the uterus in hopes to find whatever it is that's causing the bleeding, like if she had some sort of fibroid or polyp or hyperplasia of the endometrial tissue or something. I don't know. Whatever. So she could have a D&C done. An endometrial ablation is a procedure where they go in and basically they take as much of the uterine tissue as possible, and it creates scarring, and then it does not typically regenerate. They can do this by heat therapy, by cryotherapy, electric therapy, electrically burning, or whatever. So that's what endometrial ablation is. Or they could do a hysterectomy if she's having. I do know a lot of women who have had hysterectomies because they've had abnormal uterine bleeding. They've tried other therapies, medical therapies. They've tried D&Cs. And some of these women, they bleed for weeks at a time, and they have a week off and then they bleed for a week at a time, and they've not found any other hormonal reason or any other cancer reason or any other reasons. They can't get it to stop, so they end up having a hysterectomy. A hysterectomy is the removal of the uterus. Usually when they do a hysterectomy, they take the whole uterus and cervix, especially if it's cancer, malignant related. They take everything and possibly even take the ovaries during hysterectomy. But they can maybe only take part of the uterus, like the top part of the uterus, and leave the lower segment and the cervix. And they definitely can be leaving the ovaries and fallopian tubes as well. So they could do an abdominal hysterectomy. That's where they cut the belly open, just like they did a C-section, and they can remove the uterus. Or they can do it vaginal. They can do it vaginal, and they can do it laparoscopic. And then, of course, robotic. I think I told you about the robotic surgeries. I'm not sure, but where they have the robot actually doing the procedure. So depending on the type of hysterectomy she had will depend on her recovery time. If she just had a vaginal hysterectomy, then her recovery time is probably only a week or two. If she had a laparoscopic vaginal hysterectomy, then it might be 3 to 4 weeks. If she had an abdominal hysterectomy, it's probably going to be 6 weeks. And then pre-surgery care is essential. So what that means is it's not so much the care, it's not so much so what it is just making sure that this person is coming to this decision. You know, a hysterectomy, you can't reverse this. So, you know, it's just a lot of counseling before, making sure that they are sure they want to have this hysterectomy. That patient I was telling you about, her OBGYN knew that she was trying to get pregnant for a long time, and she wasn't successful. And when she decided to do a hysterectomy, her OBGYN said, okay, well, in 6 months, if you still want it, I'll give it to you. But she wouldn't do it, and until she thought long and hard about it, because it is a very big decision to make. So that's what the pre-surgery care is really all about. All right, ovarian tumors. There's a million different kind of ovarian tumors. We're just going to talk about some of the common types. Follicular cyst or ovarian cyst, really the same thing, because the follicle is in the ovary. So of course it's developed during the follicular phase when the follicle is growing. And so what happens here is the follicle is growing, it's getting mature, and it's then supposed to spit out an egg or ovulate. Well, that does not occur. Okay, so it just continues to grow, and then just continues to grow inside the ovary, becomes very large, fluid-filled cyst, and it may cause pain, or it may be asymptomatic. So it's diagnosed by bimanual exam. So a bimanual exam is a vaginal exam, so where the practitioner is trying to so put pressure internally and put pressure externally to try to palpate that ovary and feel that it's enlarged. But definitely, even though she does that, she may or may not be able to feel that enlarged ovary. So an ultrasound is really the best way to confirm this cyst. But also, we want to rule out pregnancy, because, you know, therapies that we would do for this would probably harm a pregnancy. But most often, they will resolve without intervention, but then we may need to give contraceptives to resolve these or prevent these. Now, similarly, there's the corpus luteum cyst. So that follicle did mature. It did ovulate, and now we're left with the corpus luteum. And then, so that, instead of that, corpus luteum, you know, eventually degrading and going away, it kind of gets filled with fluid or blood, becomes a big old cyst, and those may rupture and cause pain. In that case, or they may need to be surgically removed if they just keep causing problems. But generally, hopefully, and most often times, they generally resolve without intervention. Okay, polycystic ovarian syndrome. So this is caused by an endocrine imbalance. We have increased estrogen, increased testosterone, and increased luteinizing hormone beyond what is normal for the menstrual cycle. But then we have the decreased follicle stimulating hormone. So what happens is we have multiple follicular cysts, follicles that develop into a cyst in either one or both ovaries, and then those continue to produce excessive estrogen and cause problems. So many times women with polycystic ovarian syndrome, they have problems with obesity, hirsutism. So hirsutism is the abnormal hair growth on the face. They can have a problem with acne. They can have problems with infertility because the hormones are not working correctly. They can have irregular menses because the hormones aren't working correctly. And they can have insulin resistance, which would put them at increased risk for, they would have high blood sugars, so they would be at increased risk for diabetes. They're at risk for coronary artery disease, hypertension, cancer, and lipid problems. We often diagnose this in adolescence. Okay. See if there's anything else I want to say. There is something I want to say about this. I think it's in my special notes, so I'll wait till then. So the treatment is dependent on whether or not they want to become pregnant. If they want to become pregnant, then if they don't want to become pregnant, we give them contraceptive hormones, low-dose contraceptive hormones. And then if they want to become pregnant, we may need to give them medications to induce ovulation because those hormones are not working correctly. We're not having normal follicular growth. We're not having ovulation. And so we might need to give medications to induce ovulation. And then irregardless of whether she wants to be pregnant or not, she's probably going to be on metformin because she probably does have some sort of insulin resistance. Now, patient counseling is huge for these people. We'd like to have them on, of course, a nice healthy diet. We want them on an exercise program, and hopefully with the diet and exercise we can help them to lose weight and decrease their risk for diabetes, for coronary artery disease, hyperlipidemia, and things like that. And there's a lot of support groups and a lot of resources out there for people with PCOS, especially if these people are wanting to be pregnant and can't be pregnant. And then also support groups for, so like if someone has severe acne problems, if they have hirsutism, some of these things, obesity, they may have self-esteem issues, they may have, issues like that where they need counseling and support. Okay. All right, ovarian cancer, it's the leading cause of gynecological deaths, okay, and it's the fourth most common cause of cancer deaths. Ovarian cancer typically happens in the older population, and the causes are really kind of unknown, but there are a lot of risk factors associated with cancer and ovarian cancer. Signs and symptoms can be vague or even can be asymptomatic for a while, but typically people who have ovarian cancer, they do have pelvic pain or discomfort. They can have ovarian enlargement, so they could have their abdomen can be enlarged. They can have back pain if it's putting pressure on any of their nerves. They can have indigestion problems, inability to eat, things like that, bloating and constipation, urinary problems related to the pressure of a big, huge cancerous ovary. And then by the time these very vague or asymptomatic symptoms are discovered, it's already metastasized. So that's why it's one of the big cancer cancer killers. So we've got to promote ovarian cancer awareness, and especially the signs and symptoms. The people who are at risk, who still have ovaries. So people over 60, if they still have their ovaries, then they need to be educated about making sure they have their exams and reporting any signs and symptoms that are vaguely related to ovarian cancer. We need to do a laparotomy to biopsy and confirm the cancer and then stage it. Now, treatment for it is a hysterectomy with a bilateral salpingopectomy, and that is removing the uterus, the fallopian tubes, and the ovaries, and then followed by chemotherapy. And then just depending on the metastasis will determine the prognosis. Endometrial cancer, so that's the most common gynae malignancy, but the survival rates are very good for this one, especially if detected early. It happens, the majority of endometrial cancer patients are over 50 years of age, and developing endometrial cancer, the cause is unknown, but there's a lot of risk factors. It's related to endometrial hyperplasia. So these are usually estrogen dependent and with unopposed estrogen. So what that means is we don't have progesterone to be the yin and yang and to balance out our estrogen. So that's why these usually occur. Signs and symptoms is if she's postmenopausal, she'll have vaginal bleeding. If she's perimenopausal, she'll have a heavy or prolonged menses. Now, we haven't talked about menopause yet, but postmenopausal means that this person has not had a menstrual period for 12 months and is assumed to will not have menstrual bleeding. So if she starts having bleeding, then that's a concern. Perimenopausal means that she is starting to develop or go into the menopausal years, so her bleedings can be very irregular at that point, but if they are heavy or prolonged, then that's a concern. Spotting or bleeding, of course, between menses is always a concern. Pelvic pain is a concern. Dyspareunia is a concern. And then weight loss, unexplained weight loss, or unintentional weight loss is also a concern. So diagnostically, of course, we're going to do a history. We are going to do a manual evaluation of the uterus. So if it's enlarged or if we feel any masses, of course, we need to do a biopsy. And then the chest x-ray, abdominal CT, of course, chest x-ray, we're looking for metastasis. We might even need to do liver or renal function tests, bone scans, and other things to just determine metastasis. Now, if we diagnose cancer, of course, endometrial cancer, of course, we really want to do a hysterectomy with a BSO, bilateral salpingopectomy. So that means we remove both the fallopian tubes and the ovaries. And then we want to definitely also take local lymph nodes in the pelvic cavity. Will probably be followed by radiation and may even also chemotherapy. And then if someone does not have a uterus, or ovaries, a uterus or ovaries, then they may need hormone replacement therapy, if they so desire. Okay, you don't have to take hormones just because you've had a hysterectomy and BSO, but you may want to. So that is a patient decision. We need to give them education about all the different options, all the different CAM therapies, all the different herbal therapies and supplements that they could possibly try besides hormones. But anyways, that might be, hormones might be an option. Okay. All right. Moving on. Vulval disorders, or the vulva disorders. So all the most of the vulva disorders are going to involve itching and irritation of some way, shape, or form to the vulva. Most of them will cause that. Okay, we may have swelling, pain, or swelling, and those are usually related to the Bartholin gland abscess. There may be wart-like growths on the vulva, and then we may have skin changes that we need to investigate. So we're going to talk about all those different things. So vaginal infections, so we've already talked about yeast infections. We're going to move on to the Bartholin's gland abscesses. Usually these are, I can't say all the time, but most often these are very benign cysts that can either be asymptomatic or painful. So those Bartholin glands, they can, get fluid filled and swell and cause a lot of pain and tenderness. Definitely because of their location. We all know our anatomy, right? It can cause dyspareunia, and they may resolve on their own, or they may need to be drained. And I did, one of the nurses that I worked with years ago, she had gland. Her husband was a traveling oil guy or something like that. Anyways, he came home on leave or whatever, and of course they enjoyed each other's company for the short time he was home. But she ended up with both her Bartholin glands became super edematous with huge cysts, and they did need to be drained. So it was kind of a funny story. We tease her about it all the time. Anyways. Okay, so we might have vulvular parasites, lice or mites. If you can get lice in your hair, you can get lice in your hair, and so that can be a problem. She can also have scabies infection that will need to be treated. Molluscum contagiosum is a rash. It's caused by the pox virus. Vulvular condylomata, or warts, which are caused by strains of the HPV virus. They can be different from the ones that cause the cervical cancer lesions, and those can be treated with chemicals or cryosurgery, laser surgery, or something like that, but they'll probably recur. Okay, and the next couple, I have never, so let's go back. So the lichen simplex, lichen sclerosus, and the lichen planus. I'm going to let you go ahead and read about those. I have no experience with these at all. I've never seen them before, but I guess they are possible problems of the vulva. So I'll let you read over those for your information. Okay. And then these next kind, so the vulvar intraepithelial neoplasia. This is a precursor, cancer precursor associated with the HPV virus. If this is a problem, then we need to biopsy. You can diagnose it visually, but typically biopsy is the hallmark diagnostic procedure. These can be surgically removed, surgical excision, laser removal. But if this does occur, then they're probably going to reoccur, and we know that this is a precancer. These are precancerous lesions, so or precursor to cancer. So she could develop vulvar cancer from this. If she does have these, if your patient does have these, we can give her the HPV, the 4-1. Is that the Gardasil? What is that one? I'm sorry, I'm blanking on which is the 4-1. So the 4 different strains of, let me look, the 4 different strains, HPV, blah, 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 blah. So it doesn't say the name, but I think it's the Gardasil 9. So anyways, we can vaccinate her with HPV in hopes of decreasing the risk of developing a cancer. So that's an option. So the melanoma and the Paget's disease, so both of those, again, need biopsies, and both of those can have surgical excisions done if those occur. So you can read about those for your information. All right, vulvar health. We've kind of already hit on this. The same with yeast and UTI prevention, like avoid irritants, avoid putting harsh things on your vulva, wear cotton underwear, keep the area clean and dry, avoid douching, and teach vulvar self-exam. So just like with the breast self-exam, you know, they want to visualize and look at and feel for lesions, or and then look at their vulva and make sure it appears normal. And doing this on a regular basis so they can say whether something's normal or not. All right. Okay. So that's all for that chapter. And I'm actually not going to lecture on chapter 5, but I do want you to review chapter 5. Make sure you review chapter 5. Okay? This is basically about sexually transmitted diseases, okay? So I want you to know about sexually transmitted diseases, but I don't need to read these slides to you. Okay? This is something that you can look over, and I want you to know the signs and symptoms of the particular STD and the treatment. Okay, so I'll kind of go over some of those things more specifically, but the main ones. So the main STDs, chlamydia is so I'll just read my notes, but these main STDs, okay, pelvic inflammatory disease. I want you to know, okay, so let me just, okay, this is what I'm going to do. Gosh. So HIV and AIDS, so you can just kind of review this information, okay? Risk factors, screening. I don't know if you know about this, what the CDC recommends as opt-out testing and opt-in testing, but I'll just kind of explain to you. So opt-out testing means that all patients will be notified that, so if we practice opt-out testing in my clinic, all of my patients that come in are going to be tested for HIV. I'm going to tell them that it is our routine practice to test for HIV. And so unless the patient says, no, I don't want you doing that to me, then it is assumed or understood, or it is understood that they are agreeing to the test. So they have to opt out. That's what opt-out testing is. Opt-in testing is that we offered the test to the patients and they must give us permission. So opt-in is they must give us permission to do it. Opt-out is they must tell us not to do it. Otherwise, opt-out testing, we're going to do it. Okay? ACOG, American College of Obstetricians and Gynecologists, recommends that women ages 19 to 64 that we do routine testing on women ages 19 to 64, and of course at-risk populations, which you know, will fall in that 19 to 64 range, but at-risk populations can be the 16 age range. Okay, the United States Preventative Task Force routine screening for ages 15 to 65 and at-risk populations. So we test all pregnant women for HIV. As far as gynecological testing, I think most providers are an opt-in. I don't think it's a routine screening, even though there's recommendations for it to be routine. I think it's basically an opt-in type of deal, at least in this community. Okay, let's see. Chlamydia infection, very common. I want you to know about chlamydia infection, what the signs and symptoms are, and then what the treatment is. Okay, let me think. Okay, and what the treatment is. You don't have to know all the alternatives, but what is the preferred treatment, which is azithromycin. Okay, gonorrhea. I want you to know the signs and symptoms of gonorrhea and what the basic treatment is for that. Trichomonas, please kind of just be aware of trichomonas, okay? And aware of the treatment for trichomonas. Pelvic inflammatory disease, I want you to know about pelvic inflammatory disease. I think I'll have to refer to my special notes. HPV, this is important for you to know, HPV, okay. Herpes, I want you to know what herpes 1 and 2 are, the differentiation between herpes 1 and 2, what the sign and symptoms is for herpes 1 and 2, and then there's really no treatment for herpes, but what is the treatment for suppression of symptoms? Okay, so especially in the pregnant population, what is the treatment for suppression of symptoms? Syphilis, I just want you to kind of know what syphilis is, and the primary treatment for syphilis. Okay. Hepatitis B, I think it would be good for you to know about the different types of hepatitis B, especially for future adult nursing courses. Okay, so there's Hep A, just kind of know about Hep A, kind of know about Hep B, kind of know about Hep C, kind of know about hepatitis D. Okay. Okay. And then so the rest of those things, you can kind of just read over those so that you are aware of their existence. And then STD, STI, education and counseling. So we need to make sure that, we're talking to that we use our therapeutic communication for one, okay? And that we're teaching our patients about the risks associated with contracting STDs, ways to prevent getting an STDs, why it's important to include partners in diagnosis and treatment, and things like that. Okay, so what would our education and counseling be for our patients? All right, so let's just review my notes. So I have asked, or on the exam, there are 5, 6, 7. There's at least 7 questions that are related to PMS and PMDD. So you need to know the differences between PMS and PMDD, how we diagnose them, and what are some CAM therapies we can offer for our patients, and and then I also wanted to just talk to you guys about any patient. It doesn't have to be a female patient. It can be a male patient. Any patient who comes into your clinic or you walk into their hospital room, and after talking with them, they express depression, feelings of depression and worthlessness, despite the reasons why they're there. What would you do with that information? Like, should we just be like, oh, I'm so sorry to hear about that? Like, what concern do you have? What safety concern do you have for this patient? And that is your priority, okay, is addressing that safety concern, okay? There are 2 questions that talk about self-breast exams, so you should probably know about self-breast exams. And then related to that, you'll be teaching your patient about self-breast exams and about clinical breast exams, and when should they schedule their clinical breast exams. We talked about something that I don't think any patient wants to hear, and that is she found a lump on her breast, and she's with a practitioner, and they are like, well, let's check you out next month. So why? So talk to me, or not talk to me, but explain to the patient why we would want to wait till the next menstrual period to follow up on that. With breast cancers, most of them are diagnosed by mammogram, except for one. One of the types of breast cancers you can't diagnose by mammogram. So you should probably know about that type of cancer. And there's different types, different treatments for benign breast cysts. So you should probably be aware of those types of treatments for benign breast cysts, and also knowing the differences between fine needle and core needle aspiration, when it's best to use fine needle, when it's best to use core needle, and what the patient can expect as far as care afterwards. When it comes to breast cancer, there's a lot of cancers that we talk about. Well, in general, you should know all the different types of breast cancers. Just in general, what are the different types of breast cancers, and what is meant by those breast cancers in situ, or in situ, or however you pronounce that. Okay. I am going to actually give you the answer to question number 17. It involves that slide that I wanted to get rid of that has to do with the different types of abnormal bleeding. And so I can't remember, wait. Oh, okay. So I don't really remember what the question asked, but I think it asked something about intramenstrual bleeding. But the correct answer is number 2, bleeding that occurs more often than once every 21 days. I'm sorry, but I hate that, and I wish I would have got rid of it, and I didn't. And so there's another question that I actually wanted to give you the answer to. It's question number 6. I don't know if it's going to come up as number 6 for you, but the question reads, a woman asked the nurse if eating soy nuts will decrease her PMS symptoms. Which response by the nurse is best? I'm going to tell you the answer is number 2. Research has not proven or disproven the effects of soy on PMS, despite what I said in lecture. Okay, so that's the correct answer on the quiz, on the test. All right, moving on. Dysmenorrhea. What treatment do we recommend and why? I said that in the beginning of this recording. That's all I'm going to say. Yeast infections. So what kind of, you have a patient who especially has a patient with yeast infections or recurrent yeast infections. What are one of the tests? So remember, yeast infection, we can basically diagnose on signs and symptoms, as well as microscope seeing yeast cells. But what is one other thing we can, what other tests that we can do for a patient who has yeast infections, especially recurrent yeast infections? What investigation might we want to do that, what lab tests or what tests might we want to do that may indicate why she keeps having yeast infections? Toxic shock syndrome. What is the main reason why people got toxic shock syndrome? Oh, crap. And the main prevention. I am going to have to finish this. I'm sorry. I do have to finish this. I'm supposed to be somewhere like in 2 minutes. So here's this, and I'm going to finish the rest of it later. Sorry.